My name is Shrishna. I'm a PhD candidate at the Department of Political Science. I am the moderator for today's session. In the interest of time, we're going to get started as people continue to log in and join in the conversation. On that note, I welcome you all to the Rockefeller College Lunch and Learn series. These events will be taking place throughout the semester. The intention of the Lunch and Learn series is to highlight our faculty's experience and learn about their research and its impact on society. During the 1 hour, we get to discuss some of the most critical issues in politics and public policy in the country and around the world. For today's session, we are pleased to have Professors Gus Birkhead, Erika Martin, and Ashley Fox join us. Let me give a round of introductions of our panelists. Professor Gus Birkhead, MD, MPH, is Professor Emeritus in the Department of Epidemiology and Biostatistics at the College of Integrated Health Sciences at UAlbany. Until 2015, Professor Birkhead worked at the New York State Department of Health for 27 years in positions of increasing responsibility. From 2007 to 2015, he was the Deputy Commissioner for all public health programs. He holds an MD and a Master of Public Health and is a graduate of the CDC Epidemic Intelligence Service and the Preventive Medicine Residency programs. He's both certified in internal medicine and preventive medicine. He's the co-author of over 150 publications in the peer-reviewed literature, 2 public health textbooks, and 9 book chapters. In the early 2000s, he served on the Federal Advisory Committee on Immunization Practices, and from 2006 to 2011, served on the Federal National Vaccine Advisory Committee. Professor Erika Martin is a professor of public administration and policy at Rockefeller College. She's a faculty affiliate in the Department of Health Policy, Management and Behavior, the Center for Collaborative HIV Research in Practice and Policy, and the Center for Technology in Government. Her research uses quantitative and qualitative methods to evaluate programs and policies with expertise in public health services and systems, infectious disease, public health data systems and open data platforms, and evidence-based practice. Professor Martin has a PhD in health policy and administration from Yale University, a master's in public health and epidemiology from the University of Michigan, and a BA from Brown University. Professor Ashley Fox is an associate professor in the Department of Public Administration and Policy at UAlbany. She earned her BA and MA in political science from the University of Connecticut and a PhD in socio-medical sciences from Columbia University. She was a postdoc fellow in the Department of Global Health and Population at Harvard University between 2009 and 10, and at Yale University in the Division of Health Policy and Administration between 2010 and 11. Her research focuses on health politics and policy in both the US and globally. Her recent research has focused on vaccine hesitancy and health misinformation. Today's topic is public health at a crossroads, vaccination policy, and the Make America Healthy Again movement. This panel will explore recent changes to vaccination guidelines and vaccine exemption laws, what is driving these changes, and their implications for vaccine confidence and public health in the coming years. The panel will also explore the likely impact of the shrinking of the public health workforce and the Make America Healthy Again movement on our health and well-being in New York and beyond. Before I turn it over to our speakers, let me go over the ground rules. You're all requested to remain muted and hold your questions until the presentation is over. We're going to have time for Q&A towards the end of the panel discussion. You can use the raise your hand function on Zoom or send your question in the chat here. If you would like to remain anonymous, you can send your question in a private message to me here, and I will read the question for you. If you submitted a question in advance, I'm going to read it out. And with that, I'm going to invite Professor Fox for her opening remarks.
Great, thank you so much. I'm going to share my slides here and set my timer so I don't, I need need sharing privileges if, I don't know, Renee, if you can grant that. All right, here we go. Great. So I'm going to focus my 10 to 12 minutes of speaking on talking about kind of setting the backdrop for this Make America Healthy Again movement that has emerged in recent years. And I'll try to set the stage for the other remarks that my colleagues can pick up on. So the what is exactly the Make America Healthy Again movement? So first, the Make America Healthy Again movement it's the name of a commission that was established under President Trump's executive order in February of 2025. But obviously, it's a bit broader than that. In addition to that, it's sort of a play on this Make America Great Again slogan of the Trump administration and linked to this kind of broader America First agenda. But I refer to it as a movement and not just a commission because it's clear that it's bigger than this commission alone, right? And it sort of has spawned this whole movement. It has a really heavy focus on vaccines and is linked to the anti-vax movement, but it's broader than this as well. And so I'm going to talk about, I'm not going to focus my remarks so much on that element of it and focus more on what its kind of broader goals are, which it has, stated that some of its goals are to reverse the chronic disease epidemic, particularly in children, and address issues like poor diet, environmental toxins, physical inactivity, and banning certain food additives and food dyes. But I will argue that it's not necessarily a particularly ideologically coherent movement. So obviously the face of the MAHA movement is really RFK Jr. And, some people more cynically perhaps would argue that MAHA is largely just a cover for some of his broader anti-vaccination agenda, which the Trump administration has given a somewhat convenient platform for. But I want to give a little quick background on RFK Jr. and his kind of evolution. His beliefs around particularly vaccines have really evolved and largely are arguably rooted in his broader, his early experience as an environmental lawyer and his time focused on clean water and, trying to bring about greater corporate accountability for pollution. But his beliefs evolved and vaccines became really the subject of his scrutiny around 2005 to 2007. He funded this organization called the Children's Health Defense, not to be confused with the Children's Defense Fund, which has a very similar name, and that can be very confusing. But the Children's Health Defense is a very different organization, which sounds legitimate enough and really began by linking chemical pollution to various public health risks, but it quickly kind of evolved into being a sort of having a very profound anti-vaccination focus. And this really culminated in 2019 when there was this very bad measles outbreak in Samoa that was linked to some of the misinformation that was spread by the Children's Health Defense, leading to about 80 or more children dying of measles on this small island nation. And then, of course, during the COVID-19 pandemic, there were a lot of his views around skepticism around the mRNA vaccines and 5G technologies, et cetera, sort of came out. And then he himself entered into what was ultimately a failed presidential bid and was later given an appointment by Trump after dropping out as a third-party candidate. And of course, became the appointed Secretary of Health and Human Services in 2025. So the first report from the Make America Healthy Again Commission was released in May of 2025 amid a lot of controversy over its approach and its apparent over-reliance on ChatGPT. There was a lot of controversies around various hallucinations that were produced and like false references to non-existent studies. But, on the face of it, some of the general themes that the report addressed are consistent with mainstream public health practice, right? So, for instance, the focus on food system reform, ultra processed foods, food additives, stricter scrutiny of pesticides. These are all things that are fairly consistent with, mainstream public health. But then others like restricting SNAP purchases or scrutiny of certainly vaccines, but also psychiatric medications and over medicalization more generally are, arguably more questionable from a public health perspective. But what I want to argue, although I don't have time to fully elaborate this, is that the Make America Healthy Again movement is not really a new phenomenon, but is part of this sort of broader medical, what we might call health populism or medical populism that has been gaining ascendance and actually has somewhat shifted from more the political left to the political right. So for instance, historically, things like the natural childbirth movement or, eating organic or vegan diets or even vaccine skepticism itself was previously more associated actually with people on the political left, sort of this kind of crunchy granola left type of set of behaviors. But in more recent years, this has been taken on sort of by the Make America Healthy Again movement and the political right. So what exactly is health populism? One definition of this from Lasco and Cureto stresses this idea that we can think of medical populism as political rhetoric that is designed to appeal to the people, for instance, as pitted against the establishment or some kind of dominant power structure, and that simplifies and dramatizes discourse by exaggerating threats and offering common sense solutions to complex issues. So I'm going to come back to that because I think that that is one of the biggest potential criticisms of the MAHA movement is that it purports to be offering these kind of common sense solutions, but it may actually be really oversimplifying science in a way that could be very dangerous for people. And I think this, really started to emerge during COVID. It was just when we started to see this real polarization, not just in people's attitudes and beliefs, but actually also in their behaviors, which is perhaps, even more concerning from a public health perspective. It's sort of natural that people might have different beliefs about things, but to see that expressed in behaviors is very concerning. So just a couple more points and then I'll wrap up. Another sort of interesting phenomena related to this is we've started seeing the rise of what are increasingly being referred to as MAHA moms. So these are mothers who align themselves with MAHA's sort of health, freedom, and wellness agenda. They kind of merge wellness influencer culture around organic food, avoidance of toxins, and holistic parenting with political activism under this MAHA banner. And they have formed these coalitions like MAHA Mamas and the MAHA Mom Coalition, et cetera. And, I think we've also started to see some other kind of interesting, maybe slightly bizarre and weird ideas emerging from the wellness industry and integrating with this MAHA movement. So for instance, there's this kind of wellness trend around beef tallow versus seed oil. So like beef tallow is supposed to be healthier than seed oils, like olive oil. And this is starting to now like enter the mainstream and actually even become represented in policy, which, is very, I think, concerning from a public health perspective, because traditionally we have thought that, extra virgin olive oil is, lower in saturated fat. It's healthier than these kinds of animal fats. Anyway, if time permits, we can go over that more towards the end in the Q&A. Just really briefly, and then I'm going to wrap up. What has MAHA accomplished? Obviously there were massive cuts to HHS and NIH and public health during the sort of Doge period. There was a lot of data that was discontinued. It did revoke authorization of red dye number 3, which nobody really thinks, even mainstream public health does not think is a bad thing. But it's also, we've seen a surge in measles cases and a rise in childhood vaccine hesitancy. We've seen, appointments of advisory panel members linked to vaccine skepticism. I think others will talk about that. We had the recent autism report that was released that tried to pin autism on Tylenol in ways that are very concerning. We've seen the relaxation of various COVID-19 vaccine recommendations. And we're also seeing a flurry of state bills that are aimed at banning things like food dyes and ultra-processed foods in ways that, again, maybe not the best because they're not really addressing the root causes of the problems. So I'll just sort of round this out by saying, I think there are ways that the MAHA movement is consistent with mainstream public health practice, and that's why this can be really confusing sometimes because, there are things that mainstream people in public health agree on, like the fact that, yes, ultra processed foods are probably not great for you. There probably is too much influence of big pharma in the FDA. Environmental toxins are harmful to people's health. But I think the challenge is that the MAHA movement is really focused too much on these silver bullets, like banning a single ingredient or oversimplifying complex causation. So what I would, sort of propose moving forward is, some, I think, promising ways that people are still trying to combat some of the misinformation that's coming out of even some of our legitimate, national reports, right, are just to have better communication strategies from public health experts that acknowledge people's justified mistrust of, for instance, the pharmaceutical industry, that recognize how mistrust is being weaponized for political ends and to, point out when that is happening. But also to acknowledge points of agreement, right? Like areas where the MAHA, yes, we all think that people are eating too much ultra-processed foods, but then also to show points of disagreement, right? And then the last thing I'll say is just that I think we need to continue to have more research on how health beliefs and behaviors are polarizing politically. And really, COVID was the first time that we started collecting public health data that was linked to party identification, or we started asking party identification on public health surveys. And I would just advocate that we continue to do that so that we can continue to monitor how our health beliefs and behaviors are continuing to polarize politically. So thank you very much, and I will pass it on to others.
Thank you for your remarks. Over to Professor Martin.
Like you'd think that I'd never been on Zoom before. Let me just, okay. All right, can you see the correct screen? Yes, fabulous. All right. So those were some really helpful comments, I think help set the stage. And then I'll talk a little bit more specifically about vaccines in terms of the exemption laws, some trends in vaccination rates, and then this erosion of public confidence in health. And so specifically, I'll talk through, why vaccines are critical to public health strategies. So I just noticed we have a lot of folks from the health department on this call, so some of this will not be new news. But then we'll kind of go through some of the recent changes, this vaccine mandates, this erosion of public confidence, and then the public health impacts that we are already starting to see. So just to start off here, why do we vaccinate? Vaccines save lives. So the eradication of smallpox worldwide has been considered one of the largest successes in public health. And this isn't just a question of death, it's also disability. So you might think the flu, for example, can cause someone to be missing from work or school for 1 or 2 weeks, right? And that is like a temporary disability. And then some of these childhood diseases also can confer lifelong disabilities. So polio is an example. My great-grandmother had a leg deformity. She had difficulty walking. She had some paralysis. These are the kinds of things that we just don't see anymore, but used to be much more common with these early childhood diseases. The other reason why to vaccinate is that there's a really good business case for this. So vaccines are cost saving. And so I say cost saving, not just cost effective, because a lot of the interventions we do in healthcare, they're cost effective. We think they're a good value for the money, but they still cost something. Vaccines are one of the few interventions that actually save money. So Every dollar spent on early childhood immunizations results in $11 saved. And then there's another study that estimated the return on investment for immunizations among adults to be a benefit of 1 to 19, so $19 saved for every dollar invested. So it's unheard of to see other kinds of interventions with this kind of benefit. So how do we actually mandate vaccines and get people to vaccinate? So public health, like many other policy areas, is very decentralized. So enforcement of vaccine mandates is primarily left to the states. Most commonly, you see vaccine requirements for entry to schools, so elementary schools, high schools, daycares, college campuses. There are also requirements for healthcare workers and residents of healthcare facilities, because these are people who are interacting with very high-risk, vulnerable populations, such as the elderly, who are very susceptible to high-risk disease. The federal government can do some things, even though it can't mandate vaccines for everyone. So they can require some vaccines among military personnel. If there's government contractors, they can require those employees to be vaccinated. And agencies can tie funding to vaccine requirements. So for example, Centers for Medicare and Medicaid Services can require healthcare workers in facilities that receive federal funds to be vaccinated. So what makes this confusing, like many things in health policy in the US, is that things differ across the country. So all states allow for medical exemptions for vaccines. And so those are the states that you see in red. So every state, if your child has a medical reason why they can't have a vaccine, the parent can get an exemption for that. But some states allow religious exemptions, other states allow personal belief exemptions, and some require both. And then also, depending on the state, there's a very different amount of paperwork that's required for a parent to get a vaccination, an exemption. So this is a polar graph. Until preparing these slides, I'd never heard of a polar graph. I would not recommend ever using one. It's confusing, but this is a study that CDC put together. This is a little outdated. This is a study as of 2019, a legal epidemiology study. But you see here around the circle is all of the different states. They're broken up by region. And the concentric rings are different kinds of policies. So as of 2019, there were 4 states that are in red that had medical exemptions only. And then what you see is 17 states at this time had medical, religious, and philosophical exemptions, and that's the teal color, which is the 3rd ring from the outside. But what I find interesting about this graph, besides that it looks confusing, is that this doesn't just follow a red state, blue state kind of trend. So Oregon, Washington, and Colorado allowed for all of these philosophical exemptions to vaccines, and they're states that we think of as being more liberal. But Utah, Arkansas, and Louisiana were also in that list. So it doesn't quite align with just red states are allowing more exemptions. Within the states with the philosophical exemption, you might have additional policies, like whether the state requires parental education on vaccination and the whole application process for an exemption, whether a public notary is required for one of these exemptions, and requiring parents to acknowledge an exclusion for these vaccinations during an outbreak. And so again, it's very nuanced within every single state. So what is the controversy over vaccines? If I started this by saying they save people, they save lives, and they save money. There's one important argument that vaccine mandates infringe on civil liberties, which is what you can see in this protest sign here. The ACLU and others have invalidated this argument. They said that really because the vaccines protect vulnerable populations, they don't see a civil liberties violation, and courts that have allowed for vaccine mandates have agreed in the past on this. So that's one of the big arguments. And the second one, beyond the civil liberties argument, and the one that's really gaining a lot of traction, is this very widely cited study by Wakefield that showed a link between autism and the MMR vaccine. And so this article was discredited. The article was retracted. A lot of other scientific articles since then have looked for a link, and they haven't found a link. So there is not a lot of scientific evidence for this link, but this belief for this link continues. And it used to be more of a fringe belief, but now it's becoming a lot more mainstream. And so what's fueling the fire here is that RFK Jr. is now directing CDC to reopen research on this link. And I think that just really contributes to this increased mistrust of science, vaccines, and public health agencies more generally. So there have been some law changes as a result of sort of this public changes in public sentiment. 9 states, so this is a pretty recent thing that came out in Kaiser Family Foundation. So 9 states have recently enacted legislation or other kinds of actions that could potentially reduce the rate of vaccines among children. So some of these are linked to medical freedoms, parental bills of rights. There's a few states that just made it easier to get one of these exemptions. And then also West Virginia, which was previously one of the 4 states that only allowed for a medical exemption of vaccines, now allows for both religious and personal belief exemptions. Curiously, only 1 state, Colorado, has actually enacted changes that could potentially maintain or increase routine vaccination rates among children. And so Colorado said that the State Board of Health should be taking into consideration recommendations of the ACIP, as well as 3 different physician groups. So really trying to expand the amount of science that they are looking at. So laws don't just change instantly. It's usually tracking political opinion. And really, I'll show you a bunch of charts, but the bottom line is that there really has been an erosion of trust in government institutions like CDC and FDA. People are turning to their doctors and physicians for advice. So that, that is a good thing. And so that's something you can see across both parties. But following what Dr. Fox was saying, there's a very strong partisan split now about trust in RFK Jr. and President Trump. And so that's some of what you'll see in these slides. So here, doctors and pediatricians are the most trusted sources of vaccine information. And so that's sort of the first bar that you see. And then you can see at the bottom, there's just a lot more across the spectrum in terms of trust in RFK Jr. or President Trump as a source of information on vaccines. In terms of changes over time, the share of Democrats who trust CDC and FDA as a source of reliable vaccine information has declined significantly. And so that could be linked to a lot of the partisanship that we're starting to see in government. And Republican trust has risen. So that's been one change that we've seen over time. Another thing that we've been finding is most Democrats trust government health agencies to provide reliable vaccine information. So although Democratic trust in these agencies has declined over time, they're still more trusting of these agencies than Republicans. And then if you look at the 2 bottom bars at the bottom, you see a huge ideological divide between Republicans who trust RFK Jr. and President Trump related to vaccines versus very, very few who identify as Democrats. I think a trend that I find concerning when in public health, fewer than half of the public health express confidence in government agencies to ensure safety of prescription drugs or vaccines, respond to disease outbreaks, or act independently. So that's why we're seeing, a lot of people here in the green bars, which are a little or none at all. And then what we also see is across partisanship, very few folks are confident in government agencies to carry out these key responsibilities around safety and effectiveness of vaccines, safety and effectiveness of prescription drugs, outbreaks to infectious disease, and acting independently. But that, again, there's this partisan split where Democrats are more likely than Republicans to express confidence specifically related to vaccine safety. And kind of pulling from Dr. Fox's comments on, politicization of science, we find that if we look at, are we paying too much attention, about the right amount of attention, or not enough attention to science with the federal government? paying that much attention, you find a huge ideological split, right? So almost 3/4 of Democrats find that CDC and FDA are not paying enough attention to science, whereas you only find this with 45% among Republicans. So again, just this theme of this very deep ideological split. Something else I found interesting here is that, you know, in terms of confidence in specific vaccines, most people are confident in the safety of many routine vaccinations, but there is this divide, again, ideologically. So if you look at the top bar, this is just looking at everyone who is included in this opinion poll. There's highest confidence for the MMR, pretty high confidence for pneumonia, shingles, a little less, but, you know, still mostly confident in the flu. And then you see this huge drop off for the COVID vaccine. Now, if we look at the bars at the bottom, where it's split apart by party ID, there's just an enormous difference along this ideological divide, with Democrats in general being far more likely to trust the vaccines, although a little less so with COVID, and then only 30% of Republicans having confidence in the safety of the COVID vaccine. So what does this mean for public health? So this has not been an instant change. This is not a change that's just happened since the beginning of this year. So this bar chart looks at different school years starting from 2019 to 2020, right? That's like when the COVID started. And we're looking at the number of states that had MMR vaccination rates at different levels. So ideally you want over 95%. That's how you get herd immunity. And what you see over time is that we have fewer and fewer states that are getting at that 95% threshold, and more states that have less than 90% of kids vaccinated with MMR. And, you know, why does this matter historically? You know, measles cases used to be very rampant. In the 1960s, we had vaccines. So between the vaccines and then in 1989, there was like a policy recommendation to have a second dose. We got to elimination of this infectious disease. And then most recently, what you can see is that there's been rises in measles cases. So nothing back to that level that where we were in 1960s, but it's alarming that a disease that has been previously eradicated is now on the rise, and we can see that in the data. And so with that, I am going to stop sharing my screen and turn it over to Dr. Birkhead.
Thank you, Professor Martin. Over to
stop.
Professor Birkhead for concluding remarks.
Thanks very much. Let me get my slides up here. So thanks everyone. What I would like to do is try to provide some perspective on the federal vaccine advisory committees that have been mentioned by the previous speakers and are in the news pretty much on a daily basis. And my perspective is partly informed by having served on several of them, and I'll talk a little bit more about that. But basically, I think if you follow the news, we've seen some controversy around these, particularly with regard to COVID, but some of the other vaccines as well. And so I'll talk a little bit about that and where we might go from here. So just by way of background, there's a system in the federal government to have advisory committees across all agencies of the federal government, not just in health. And there's a Federal Advisory Committee Act called FACA, which governs these. And it basically governs the establishment of these. Let me move folks out of the way here. Across the executive branches of the executive government. And it really defines what constitutes an advisory committee and provides general rules and basically ensures that the public are kept informed regarding the cost and the activities of these committees. And it importantly, I think, requires transparency and public involvement in making the meetings public and the records open to the public. So there are two committees which have been in the news recently. The first is the Federal Food and Drug Administration's Vaccines and Related Biologic Products Advisory Committees, or VRPAC. And that committee so these are external experts brought in to be an advisory committee to the government, reviews data on vaccine safety and efficacy to determine who should be licensed, which vaccine should be licensed. And the other committee is the Advisory Committee on Immunization Practices, the ACIP. This is the committee that I served on in the early 2000s. And it makes once a vaccine is licensed by FDA, makes the public health recommendations on who should receive the vaccine. So this is what guides public health practice and medical practice in many parts of the country. Many insurance companies and medical groups make reference to, and state laws make reference to the ACIP recommendations as to who should receive vaccinations. And the ACIP also has a role in determining which vaccines are paid for by the federal government for the Medicaid, for children on Medicaid and children who are uninsured. So the Vaccines for Children program. So both committees have pretty important roles to play in the vaccine world. And this slide sort of summarizes them. The FDA really looks at the primary question: is the vaccine safe and effective? CDC's ACIP makes recommendations about who should get it and when. The core responsibility for the VRPAC is licensure and approval. For ACIP, it's public health immunization recommendations. And VRPAC, in licensing a vaccine, relies pretty much on the scientific and technical data. ACIP can also bring in other data like cost and equity considerations in determining who should get vaccines. And the final output of each committee is for FDA is the actual approval or licensure of the vaccine, and a lot of attention is paid to the label, the verbiage that accompanies the vaccine doses that describe who it can be used for. For ACIP, the CDC director adopts the recommendations that come from ACIP and establishes what has been in the past the standard immunization schedule for children and recommendations, and for adults as well. So recently, what I think we've seen happen are a number of things, and we'll talk about the implications of these, but both the ACIP and VRPAC membership have been completely replaced in the new administration. And the FDA earlier this year announced the updated label, or in other words, the updated licensure for the COVID-19 vaccine. And those recommendations were announced on X without any public meeting occurring. And in that process, the FDA greatly restricted the COVID-19 vaccine label to persons age 65 and older and those with chronic conditions placing them at risk. This was unusual restriction for FDA to place, and sort of getting it more into the realm of recommendations for who should receive the vaccine that are really in the purview of CDC and the ACIP. So that was unusual. And ACIP followed up then, the newly constituted ACIP, with a recommendation around COVID vaccine for those all ages, basically, with shared decision-making as being recommended. And that's, we'll talk more about that, but that means you have to involve a healthcare professional. You can't just go to your pharmacy and get a vaccination. And this kind of a recommendation has been used only sparingly in the past by ACIP when the risks and benefits of a vaccine aren't clear, that it's not that there's some uncertainty. It's left up to people to talk with their doctors about. And I guess we could just argue whether COVID vaccine falls in that realm, but I don't think that my opinion is that it does not. So a number of concerns when the ACIP, and I'll speak now specifically about the ACIP because that's the committee I served on, a number of justifications for the complete changeover of the committee were given. One was that there was conflict of interest in the previous ACIP membership that tainted their outcomes. And basically what FACA, the Federal Advisory Committee Act, says is that members of ACIP and these other committees are considered to be special government employees. They are appointed to provide their own individual independent judgment based on their expertise, not as a representative of their employer. They are therefore subject to federal financial conflict of interest requirements and cannot participate in any matter that would affect their own financial interest or that of their employer. So this is in the federal law. And even 20 years ago, when I served on the ACIP, this was operative. And if you're interested, you can actually go back all the way to those meetings back in the early 2000s and up to today at this website and look at each individual member of the ACIP and what conflict of interest disclosures they made. So I think it's important to understand that most people who get to be on advisory committees have some experience in the area that they're advising on. They have conducted research or been involved in studies and may have had interactions, in this case, with pharmaceutical companies that might disqualify them from voting on that particular company's products. So if you look back at these disclosures from the ACIP membership back to 2000, you'll see things like I was funded to perform a clinical trial on a new vaccine, or I was funded to go give talks to medical societies and that kind of thing by a particular manufacturer. And I think the important thing to recognize is when you have a conflict of interest like that, that's disclosed publicly. It's disclosed in each meeting that I attended. As we went around and introduced ourselves, people disclosed their conflicts of interest. And then once you've disclosed a conflict of interest, you do not vote on anything to do with that vaccine or with that company's products. So it's even 20 years ago, and I think even more so today, it's a pretty strict system. And I think it's not correct to say that the system resulted in biased outcomes because people were disclosing. And in addition to the verbal disclosure at meetings, I think now people do have to submit a questionnaire in writing indicating what they're, even if they own stock in a company and that kind of thing. And sometimes that can also be disqualifying to vote. It was interesting for me to go back and look at some of these names. There is an individual now on the newly constituted ACIP who has served on the ACIP in the past, and that individual had conflict of interest disclosures in the past, and presumably may still today. So the argument that we needed to change the entire ACIP because of conflict of interest of the membership really, I think, doesn't hold water. Conflicts of interest were disclosed, and people didn't vote if they had one. And there are still members today on the committee that have in the past disclosed such conflicts. So that I think is one area that you may have read in the press about that. I just wanted to provide my perspective on one person's experience. A second thing to say about the ACIP system is that it uses an evidence-based approach. There is a system, and you can look at this website to see the approach that's being used by ACIP to give basically a grade to each, the strength of the evidence. And you look at evidence levels to score your recommendations based on how confident you are based on the quality of data. There's grading based on high quality, for example, double-blind clinical trials, Placebo-controlled clinical trials are probably the highest level of evidence, whereas observational studies are a somewhat lower level of evidence. There are factors which may downgrade in studies, need to be looked at closely for potential risk of bias. If you have multiple studies showing different things, that may cause you to question. And there are a variety of factors there. And in developing the recommendation, ACIP in the past, at least, has been very methodical, very formal about this process of trying to discuss each of the levels and evidence grading, and giving its recommendations basically a score on how strong the recommendation is and how strongly it's supported by the evidence in the scientific literature and that kind of thing. So where do we stand at this moment? In terms of COVID-19 for the coming season, what the FDA license says is the vaccine is licensed for people over 65 and for persons 6 to 64 years of age who have high risk. The FDA didn't define what high risk meant. CDC, the ACIP, went on to basically say everybody could get, but should decide with their clinician, but could, that's the process that you need to go through. In this, so both of these were sort of changes from how both FDA and CDC recommendations in the past had been framed and were quite much more restricting than in the past. And so what has happened is professional organizations have stepped in with their own recommendations, more similar to the past ACIP recommendations, if you will. So for COVID vaccines, the American Academy of Pediatrics, of Obstetrics and Gynecology, and family physicians recommend COVID vaccine for everybody over 18, for those 2 to 17 years with risk, or, and this is important, I think, for any parent who wants to get it for their child. So they're not restricted to high-risk kids. Any parent who wants to get it can get it. And this is important because according to CDC, you would then need to go get a prescription from your physician. So there's a limitation there, even if a parent wants it and doesn't have a risk factor. And pregnancy is another area where it was not clear, but it seemed like pregnancy was not being prioritized in the CDC recommendations, even though pregnancy is clearly listed as a risk for COVID disease during pregnancy. So we have a confusing layout here in terms of, this is just one vaccination to deal with. So I just want to summarize here some concerns about what's going on now. There's, I think, lack of a transparent process when recommendations are announced on X without having any public deliberation about them. That, I would say, is a lack of transparency. The new members of both committees in general do not have experience in clinical care, vaccine research, vaccine policy making, and seem to have all, though a common factor of having, I guess, been called, making anti-vaccination statements in the past. So that's not to say that you don't want to have a variety of views on a committee, but to have everybody with the same view maybe is not the best way to go about it. In terms of the public vetting of the scientific evidence, the grade score that I just showed you about how the ACIP used to consider recommendations was not really applied to their most recent recommendation around COVID vaccine. The grade framework wasn't used, and there was clear data of a risk of COVID-19 infection during pregnancy, which seems to have been ignored. There has been some blurring of the FDA and CDC, CIP authorities, in that the licensure now from FDA includes things that, like the restriction to high risk under 65, that in the past would be more suitable as a clinical recommendation rather than a limit on the license of the vaccine. And this restriction by ACIP of requiring consultation with a medical provider, that is a barrier. You can't just go to your pharmacy and get vaccines based on this recommendation. Now, what's happened in many states, and New York is one of them, is that the state health departments have stepped in and issued guidelines or recommendations that allow people in New York. So in New York, you should be able to go to a pharmacy without a prescription, having discussed it with your physician, and get a COVID-19 vaccine. But that may not be the place in other places, and this becomes a barrier to people who want to get vaccinated, having to go through extra steps, extra hurdles to get vaccinated. And so also the lack of a provision, as ACIP in the past with COVID has said, anybody who wants to receive it, you can get it. That is not there. And so the statements that we've read in the press attributed to RFK that anybody who wants to get a vaccine can still get it, there are barriers to that in the way the current ACIP recommendations are structured, because it doesn't say that. It requires you to go through your physician. So on top of that, we're now looking at loss of insurance coverage for many groups. So I think the combined effect of all of these things is to reduce accessibility of vaccinations, even for people who want to get them. And it's possible, I don't want to get into it, but that this could get worse with other vaccines and the discussion of adjuvants in vaccines and potentially unlicensing traditional childhood vaccines. So these are initial concerns, but it could get a lot worse. So I just wanted to finish by trying to provide some information. I think the impression people get, or the criticism that's been charged at the committees like the ACIP, simply approve rubber stamp every new vaccine that comes along. And I wanted to provide some examples of where committees and the ACIP have not done that, have actually recalled or pulled vaccines. And so in 1997, after concern about the whole cell pertussis vaccine that's part of the DTP vaccine, that vaccine was completely reformulated to reduce the side effects based on input from scientific committees. In 1999, the RotaShield rotavirus vaccine was pulled from the market and discontinued because of an increased rate in intestinal blockage that resulted from that vaccine. In the year 2000, thimerosal, ethyl mercury preservative, was removed from all childhood vaccines out of an abundance of caution. There was basically no safety concern specifically identified, but out of abundance of caution. And I would comment that there's been a lot of thimerosal has been back in the news as potentially linked to autism, which there are data to support, are not data to support. But even if it was, thimerosal has not been in childhood vaccines for the last 25 years because it was removed based on a process that included the federal advisory committees. In 2016, 2018, the FluMist nasal flu vaccine was not recommended by ACIP. They withdrew their recommendation due to a lack of efficacy against the circulating strains at that time. In 2021, the Janssen COVID vaccine was paused, and then the recommendation withdrawn, and it was pulled from the market due to side effects related to blood clots. So I would just quickly conclude that even though we do have a robust vaccine safety system in this country, even when clinical trials to license vaccine involve tens of thousands of participants, they're not large enough to detect very rare events that occur in less than 1 per 100,000 doses, for example. So there's this whole system in place, and I won't go into detail in this, but there is a multi-component system that detected some of the side effects I showed on the previous slide that resulted in pulling vaccines from the market. So the system is robust. It has worked. It is not rubber stamp every new vaccine that comes along. And the recommendations that come out of the committees in the past have been based on a very deliberative and public and open process, which I think now is in doubt. So I will stop there and try to unshare my screen and look forward to the questions.
Thank you to our panelists. We have a few minutes left for Q&A. What I'm going to do is we have a couple of questions from Colin in the chat, so I'm just going to put them together and summarize them in the interest of time, and whosoever wants to pick it up can go ahead. So the question is, what about the ideological alignment of the right and left towards anti-masking and mask bans? So I believe the question is about mask bans. And what about public masking and whether it's inconvenient to public health discourse? And if you have any remarks about a long COVID? That was another question. So I've just put that together. Whosoever wants to take that one.
I mean, I can maybe say a couple of quick things. I mean, first, I think the public health community was very upset by the Hochul's mask ban. Or I mean, it wasn't a complete mask ban, but saying in certain situations that masks would be prohibited, right? For mainly coming from the perspective of public safety. But I think the broader issue that these questions raise and that the Hochul's mask ban raises is really this more fundamental question about when is it appropriate to abridge civil liberties in the name of public health or any perceived emergency, right? And I think, to me, this was one of the fundamental things that was really in the limelight during the COVID pandemic. Was we kind of cast aside several decades of work in public health on health and human rights, which had actually laid out pretty clearly. And there still are guidelines about like when is it appropriate to abridge civil liberties in the name of public health. And one thing you want to be cautious about is abusing that, continuing to do things that might be perceived as too draconian or excessive in the name of public health, because that can also be captured and put towards, various political ends. Like, for instance, if political leaders decide to declare a state of emergency and, shut everything down or take political control, again, in the name of public health. So I think we want to be very cautious about that, but there are principles that guide that. So for instance, on the international stage, the Syracuse principles outline that, any infringements on civil liberties should be proportional to the risk, right? So like how big of a risk is it? Are the hospitals overfilling? How do we judge that? They have to be of limited duration, right? So we can't do it forever. It has to be, again, proportional to the risk we're actually facing, and then subject to review, right? So, do we need to continue these abridgments, or have we gotten to a point where, we're not in a pandemic or an epidemic, we're in an endemic situation, and then, you manage it differently. But I'll stop there in case my colleagues want to come in.
Nothing to add.
Thank you. I think we've reached, the end of the panel, and perhaps we can close with the last question in the chat. It's for Professor Birkhead. So if you can briefly respond to it, Professor Birkhead, as we close. I want to thank you all for attending, and I want to especially thank our panelists. So the question is, what is the threshold, what is the threshold for recalling a vaccine based on side effects?
So I don't think there's any particular threshold. It's a process that it considers the evidence in a considered manner, looking at the strength of the evidence, looking at the strength, the severity of the side effect. So there's a whole host of factors that would come into play. It's not a cookie cutter. There's not a particular box you check and the vaccine is recalled. It's the process that you go through with your external advisory committee, and in a public way, considering the pros and cons of continuing with the vaccine. What are its benefits? What are its risks? And that's the kind of discussion that goes on all the time when a vaccine is first licensed, and as you go forward, and people look at the studies that I cited that look at the safety. I mean, those results are considered on a regular, ongoing basis. So it's the process that determines when you reach a threshold, not a particular level or.
Thank you.
I
That was
hope that answers the question.
it does, and that was brief and to the point. So thank you for that. I want to thank you all for attending, and just want to let you know that we have the next Lunch and Learn on November 13. I look forward to seeing you all. Have a good day ahead, and thanks to our panelists. This was a great discussion. Goodbye.